What we're going to talk about this morning is FESS instrumentation and the technique of mini FESS. So Sham has alluded to the different techniques for removing the unsnip process, and we're going to go through both those techniques and go through some of the pros and cons of both of those techniques. The first thing I'd like to talk about when we discuss the beginnings of surgery is positioning. Now you'll notice that in this slide we sit down when we operate. We've got a little arm board that comes up next to the patient. You know that arm board that the anaesthetist normally uses? We swing a fairly narrow arm board up parallel to the table, and then just rest your elbow on that. Keep your wrist straight. Don't bend your wrist because you're holding a camera with the endoscope on it. And make sure that your head, the patient's head, and the monitor are in one straight line. You don't want to be turning your head and working over your shoulder or working at this angle. You should have your head, the patient's head, and the screen, the monitor, all in a straight line. So we have the scrub sister standing opposite us with a tray, handing the instruments across the table. And the anaesthetist, we try and push him out the door if we can. So we get him right to the bottom of the theatre table. And you have our x-rays over here on a mobile x-ray stand so that we can address those x-rays at any point in time. So I think positioning is very important when you start up and set up with the surgery. The instrumentation is important. There's a few basic instruments that you require before you can do good FESS. You must have a sickle knife and a backbiter. This mini backbiters, these small backbiters, are much more user-friendly. This one's a rotating one that you can turn and use it on both sides. It's a very useful instrument to have. You must have a right angle ball probe or frontal sinus probe, and you've got to have the standard Blakesley instruments, the 0 and 45 degree through cut and grasping forceps are very important. I feel that the Hayjack-Koffler punch, and I'll show you why, because we use the Hayjack-Koffler punch again and again and again for a number of instances, as an important instrument. And I like to have giraffe forceps for the frontal sinus, particularly the through-cut giraffe forceps, both 45 degree and 90 degree, and if you can, have it side biting and front to back biting as well. So those are what I think the must-haves for a basic instrumentation setup is. There are a number of other instruments which I think are very useful, and we've got to have a disclaimer before I promote this instrument, that when you buy this instrument, you'll be helping educate my children through private schools. So I do get a commission on this instrument. But what happens is, this is a suction bipolar instrument, and I will demonstrate it in the live surgery as well, is that the suction is pushed forward through this lever here ahead of the two bipolar forceps, and it can be retracted back just by letting that go. It's on a spring. The suction slides back and allows you to bipolar. So you can clear the field and utilize the bipolar suction as well. We've developed a whole set of malleable instruments which you can bend to the angle, and they have suction through them as well. And these instruments are also very useful, specifically the suction freers and the suction curette. Also the malleable frontal sinus probe, which you can bend to any angle and still dissect with it. I find a very useful instrument to have. So the basic technique of sinus surgery, we're going to just look quickly at Sham has addressed the anatomy, but we're going to just look at a few little anatomical aspects with relation to the unsnip process. I'm going to look at the two techniques. Then I'm going to look at the most important and common cause of failure of mini FESS and demonstrate that to you, because if you can avoid this in your patients, you'll have a significant improvement in your success rate of your surgery. And I'll go through an illustrative case to illustrate how this cause of failure can be avoided. And we'll just summarize that with a few key issues. The three parts of the unsnit, we'll discuss the part above the middle turbinate. So the part above the middle turbinate, the superior extension of the unsnit in the frontal recess, we'll discuss in some detail later on this morning. The middle part of the unsnit, which you're looking at just next to the adjacent to the middle turbinate, and the horizontal portion of the unsnit are the two areas of the unsnit which are really important in the dissection of the unsplenectomy and removal of the unsnip process and exposure of the natural ostium. The posterior attachment of this horizontal portion can vary. It can be a free end, or it can attach to the palatine bone. And you've just got to address each patient individually to see whether the posterior end of the Ansner process is either free or progressing to attach to the palatine bone. If you look at this axial cut, this is an axial cut through the cadaver. This is the left orbit, left middle turbinate septum. Front of the nose is here. Anterior end of the middle turbinate is here. This is the Ansner process, the nasolacrimal duct we can see there. And you can see that this Ansner process, if you remove the Ansner process, you expose the infundibulum, which is a shallow groove in the lateral nasal wall, down which a lot of the frontal sinus and anterior ethmoid sinuses drain towards the nasopharynx. So it's important that we get this Ansner process off when we remove it flush with the lateral nasal wall. What you'll think about, the first thing that you'll think about when you're doing an uncinectomy, if you're going to do the uncinectomy in the traditional manner, if you're going to use a sickle knife uncinectomy and incise that Ansner process as the first step of your dissection, then you're going to have to make the decision when you're looking at the lateral nasal wall, and you can see that the lateral nasal wall is a continuous slope, and it's very difficult to distinguish where that Ansner inserts into the lateral nasal wall. Now, there are a number of tricks that you can do to try and help that and aid that. You can palpate or push on the Ansner process, and you can see where it's rocking, where the insertion is, to see where it's rocking. But you'll find that most surgeons who use the traditional incision technique with the sickle knife will allow themselves a little bit of margin of error. In other words, they'll be a little bit conservative about where they make that first incision. So instead of making it right at the insertion of the Ansner onto the lateral nasal wall, they'll give themselves a couple of millimeters and make it further in. And that's the problem with the traditional technique, is that if you do give yourself a little bit of margin for error, that you'll leave a significant proportion of the Ansner behind, and you'll often miss the natural ostium. And I'll go through some figures for you later on. But if you're a bit of a cowboy, if you're a bit of gung-ho with your surgery and you go for the absolute insertion on every occasion, you'll find that from time to time, the first incision that you'll make directly into the orbit. And that's not a great way to start your sinus operation, is by making an incision directly into the lamina papyracea and having the orbital fat protrude with your first incision that you make for the operation. It doesn't impress the registrars at all. So the standard technique, and Sham's been through this is the technique that was described by Stamberger and Kennedy when they started FESS off, was to make an incision, a vertical incision down the Ansner process with a sickle knife or with other sharp instruments. A Cottl's elevator has sometimes been described as being a useful instrument to make this incision with. Make this incision. As you make that incision, lateralize the Ansner process. And then using a 45-degree Blakesley, you grasp that Ansner process and rotate it medially and inferiorly and remove the Ansner process. We advocate a different technique, which we call the swing door technique. You make a cut with a sickle knife right at the top of the Ansner, just underneath the axilla of the middle turbinate, to make an incision with the sickle knife. And you take the sickle knife from the free edge of the Ansner and cut as hard as you can onto the bone. You cannot go into the orbit at this point, because you do not have the thin lacrimal bone. Because we do a lot of DCR surgery, we know that the lacrimal bone comes up to about 5 millimeters underneath the axilla of the middle turbinate. So if you make an incision, a hard cut, through that Ansner process onto the frontal process of the maxilla, you cannot go into the orbit with that cut. So you can be quite safe. You can make a firm incision quite safely horizontally onto the frontal process of the maxilla without endangering the orbit. You then use the small pediatric rotating backbiter and slide it in. Use it to palpate with first. So open the instrument, use the tooth to palpate, slide it behind the Ansner process, slide it up and down the Ansner process, palpating the Ansner process, and then let it fall down as far as it will go, because this begins to turn horizontally, so it will only go down as far as it can go. So let it slide down the Ansner process as far as it can go, and then start making a number of cuts into the Ansner process. Now, depending on the size of the backbiter that you use, will depending on how many cuts that you need to make. Also depending on the length of that Ansner process. Now, that can vary fairly considerably between patients as well. So what I tend to do is that with the pediatric backbiter, the one I showed you, the rotating one, I would on average make 3 cuts, 3 backward cuts. The first cut and the second cut will be with this instrument line horizontal. So that instrument will be horizontal. But when you come to the third cut, you're coming fairly close to the nasolacrimal duct, as Shane indicated. And you really need to start to turn this instrument to 45 degrees. And as you turn that instrument with that final cut to 45 degrees, you bring the tip of that backbiter medial to the nasolacrimal duct. And you don't endanger the nasolacrimal duct. So you make 1 cut here, 1 cut here, and then the third cut is at 45 degrees. And that third cut at 45 degrees ensures that you've fully cut that unsnut process right up to its insertion with the lateral nasal wall. You then put a double right angle ball probe through that cut behind the unsnut process, put it fairly close to the insertion of the unsnut process, and then pull towards you. And by pulling towards you, you will fracture that unsnut process, and you will fracture it all the way along its insertion. So now you've got it flailed and you've got it fractured along its insertion. You then take a 45 degree through bite in Blakesley, and you don't rotate it as this arrow indicates, but you cut through this as close to this insertion of the unsnut as you possibly can. That gives you removal of the middle third of the unsnut process. So the vertical portion of the unsnut process, the middle third. The horizontal portion of the unsnut process is still there. So you haven't removed the horizontal portion, you've only removed the middle third of the unsnut process. We then will dissect the bone out of this horizontal portion of the unsnut process, and then we'll have a bit of redundant mucosa. So we'll have a bit of extra mucosa, which we'll trim back just so that we can expose that natural ostium. We don't routinely enlarge the natural ostium unless we need to work within that maxillary sinus. So if we've got significant pathology in that maxillary sinus, if there's fungal debris within the maxillary sinus, if there's massive polyposis, if there's a foreign body, if there's some reason why we want to visualize the inside of that maxillary sinus, we will then open that maxillary sinus. But if that maxillary sinus has only got diffuse mucosal thickening on the CT scan and there's no significant pathology, all we will do is just remove the unsnut process, take out the bone, trim the mucosal flaps back just to expose the natural ostium, and do nothing more than that. That'll all we will do for the surgery. If you're ever in doubt as to where that natural ostium is, if you see with this anterior aspect which you've removed the unsnut from the lateral nasal wall, if you put a curved instrument directly behind that, slide it down, that infundibulum, it has to go into the ostium. It cannot go anywhere else. It has to go into the natural ostium. The problem with the original technique is if you've left 2 or 3 millimeters behind, you can not have exposed that natural ostium, and then you can have difficulty identifying the natural ostium, and you can then have the most common mistake made in sinus surgery, which is to create a artificial ostium through the posterior fontanelle. So this is just a specimen which we've taken out to demonstrate it. This is the left side of the nose. That's the horizontal cut that we've made through the top of the unsnut process. This is the vertical, the other horizontal cut with the backbiter. This cut here we've made with a 45 degree through biting. And in most cases, we will remove this second portion of the unsnut process in one piece. So you can, by taking one cut, and another cut, and the free edge of the unsnut is there, you can remove that unsnut in one piece. So you're not taking the unsnut out in bits, you're taking it out in one piece from that lateral nasal wall. So if you're looking here, this is now on the right-hand side. We've taken this portion of the unsnut out. We're now doing the dissection of the horizontal portion of the unsnut process. So the natural ostium is here. This is the final common drainage pathway. You can see we've just raised the mucosa off this little bit of bone, and you can see how this horizontal portion of the unsnut process, how the little bony legs, how they implant into the ethmoidal process of the inferior turbinate, this portion of the unsnut process. So that you can see that you can take this unsnut bone, you can just put a little double right angle ball probe and flake it out, and you can see the unsnut process has often got a little bit of a lip on it as well, and it's got these little feet which attach to the vertical portion of the ethmoidal process of the inferior turbinate. So just by removing this little bit of bone, we've now got two mucosal flaps. We've got the natural ostium, and I'll just demonstrate that to you on a video. So we're on the patient's right side, middle turbinate is here. We've made the cut at the top. You can see one cut, two cuts. Now watch, we turn this, we start to turn that. The third cut is at 45 degrees. We fracture the Janssen process, take the 45 degree through bite in Blakesley, and we remove it absolutely flush with the lateral nasal wall. There's the natural ostium. We dissect out the little bit of bone of this horizontal portion of the Janssen process, just removing, taking the flaps out on both sides. Dissect the bone out. You can see the bone coming out there. Remove the bone from that horizontal portion, and you can just see we've got the two flaps now nicely together. We can trim those back a little bit, just one or two turns with the microdebrider. We'll just trim those back to get nice mucosa to mucosa apposition, and you can see there's the natural ostium, and there's the final common drainage pathway. And look how the blood has been stained as it goes back down into the nasopharynx. So this is, you can see the mucociliary pathway as it moves the blood down that final common drainage pathway. You can see how it streaks the blood down that final common drainage pathway. So what we've got here is we've got the two edges of the mucosa sitting right next to each other, and that allows first intention healing. Okay, you don't get a large raw area which is going to granulate up. You put the two mucosal surfaces together and you get first intention healing, like a surgical scar. And you don't get interruption of the final common drainage pathway, so that the mucosa, the mucociliary clearance of that maxillary sinus is kept intact. The most common error is surgeons who've gone in and created a posterior fontanelle. This is on the left side. You can see I've just done an uncinectomy. There's the natural ostium, and there's the posterior fontanelle. So this is the most common error. And you can make a diagnosis of this both on endoscopy, when you're evaluating the patient, and radiologically when you look at the CT scans. So this is on the right side. You can see the natural ostium with the 30-degree endoscope is just over here, and the accessory ostium is at the back. And if you follow these CT scans down, if we go from here to there, to there, to there, in the CT scans, we're looking at the right side, a pacified maxillary sinus. We can see that we're just starting to see the natural ostium as we come into view here. Starting to see the natural ostium. As we go further back, we can still see there's continuity of tissue, so we're looking at this area here, natural ostium here, which is there. The next cut is through there, which has got the tissue, and the next cut is through there, which you can see the accessory ostium going through there. So you can see with the three cuts, this one is over there. You've got tissue between it, which is here and here, and then the fourth cut, which is through there, and you can see there's a little bit of space there. That's why you've got a little bit of air that you can see coming through there. So you can make the diagnosis both on the CT scan and on endoscopy that this patient's problem is that there's been an accessory ostium created. And that accessory ostium gives you a circular flow. And you can see here, natural ostium, accessory ostium, and the flow is going into the maxillary sinus. On the other side of the nose, natural ostium, accessory ostium, and you can see the mucus flowing from the natural ostium to the accessory ostium. And just this is a particular patient who's had a large surgical antrostomy created. And as you look, you can see this thick white mucus flowing from the natural ostium behind the Janssen process, which is still there. This is all the Janssen process coming out the natural ostium and flowing into this surgically made posterior accessory ostium. The most common error that we see in sinus surgery. And it's an error that you can easily avoid, and you can easily prevent your patients from failing surgically. The complications that you can get with a mini FESS approach, adhesions, orbital penetration, lacrimal duct injury, and the way to do and prevent this is to recognize the patients who potentially can undergo these problems. This is the sort of thing we want to avoid, multiple and diffuse adhesions between the middle turbinate and the lateral nasal wall. And one of the ways that we can do that is if you've traumatized the middle turbinate, or if the middle turbinate is retrocurved. So if the middle turbinate does this, it puts this portion of the middle turbinate in close proximity to where you've operated surgically. So a retrocurved middle turbinate is something which we would like to prevent from forming adhesions. So a retrocurved middle turbinate, a floppy middle turbinate. If you've got a big septal deviation which is pushing that middle turbinate into that lateral nasal wall, all these situations where you have the potential to develop adhesions between this middle turbinate and the lateral nasal wall, what we do then is we take a dissolving suture, and I would normally use a 3/0 vicryl on a cutting needle. I'd use the Rapide, so it dissolves within 7 to 10 days, so it dissolves very quickly. We place the suture through the middle turbinate, through the septum, through the middle turbinate on the other side. Normally, if they've got two turbinates that you want to secure, if you've only got one turbinate you want to secure, you can just go through the septum, come back out and then tie a knot. And we'll show you, we've developed a little knot pusher to tie these knots, to make the tying of these knots much easier within the nose. So the knot pusher is a useful adjuvant to suturing that middle turbinate together. And then as that, all we're doing with that suture, is allowing this mucosa to heal before that stitch dissolves. So you want 7 to 10 days before that stitch dissolves for this mucosal surface to heal, for the patient to douche, to remove the blood clot. So once that stitch dissolves, this turbinate is going to start to lateralize. But once it starts to lateralize at that point, you shouldn't get adhesions anymore, because a large portion of the blood clot and fibrin has been washed away from that surface, and you shouldn't then develop an adhesion. This is the classic view of orbital penetration post-operatively. Patient who's had the orbit penetrated, there's a little bit of bleeding within the tissues of the orbit, and it will often present as an ecchymosis in the post-operative period. Now, if you do expose orbital fat, if you do use the sickle knife for your first incision and go straight through the Ansner process into the orbit and see orbit, and anybody who does a significant amount of FESS would have exposed orbital fat at some stage or the other. So orbital fat exposure is very common. Everybody, and I don't know anyone who does a lot of FESS who hasn't exposed orbital fat, because if he has, he's either not doing good FESS or he's not an honest broker. So everybody exposes orbital fat. The point about exposure of orbital fat is to recognize it immediately, is that you really need to know that you've done it. That's the important point. And the way to recognize it is just to gently palpate the eye, to push on the eye, and to see whether the orbital fat protrudes into the orbit. So if you recognize it and leave it alone, don't manipulate it, don't try and take it out, don't try and push it back, just leave it alone. No, the patient will suffer no ill effects and no side effects from that orbital exposure. Just leave it alone, don't fiddle with it, and don't try and push it back, and just work around it. Now, one of the reasons that you can expose orbital fat is if you've got what we call as an atelectatic unsnit. Now, this patient has never had an operation before. No surgery. Patient presents with maxillary sinus disease, both sides, but more prominent, and the one that's interesting in us, is the one on the right side. And if we look at the anatomy, we can see that the Ansner process has been sucked right in. So this patient has got what we call the silent sinus syndrome, because you'll notice that as the scans go further back, this orbit here gets bigger, because this has also been sucked downwards into the maxillary sinus, the infraorbital wall. And this has caused this Ansner process to become atelectatic. Now, it's like an eardrum that becomes floppy, thin, and moves medially to oppose itself on the promontory in the middle ear. So the way that you get an atelectatic middle ear, atelectatic tympanic membrane, you can get an atelectatic Ansner process, but you must recognize it before you operate on the patient. So the way to recognize this is to look at the CT scan and to see that you can see there's a significant difference between these two maxillary sinuses, and that Ansner process has been sucked right back. So let's just run through a series of CT scans of this particular patient. So you'll see that we're on this side, on the right-hand side, and you'll see that the Ansner process is going up towards the middle turbinate, and you can see that you've got this sucking in of that Ansner process. It's plastered up against the orbit. The whole Ansner process is plastered up against and even posteriorly, and you can see how this orbit is much bigger than that one. So when you go and look at the patient, This is the Ansner process in this particular patient, and you can see how thin and atelectatic it is. It's plastered up against the lamina papyracea. Now, if you used a standard approach for this, a sickle knife standard approach, I would guarantee an incision into the orbit with the first incision. There would be no way that you could avoid, with the standard approach with the sickle knife, that you could avoid incising into the orbital periosteum. But even with the backbiter, just by trying to elevate that off the orbital periosteum, you can see how thin and plastered down that Ansner process is onto that lateral nasal wall. But at least the backbiter, you can do a little bit of feeling and a bit of dissection of that Ansner process with the backbiter. Fracture that Ansner process, you can see how floppy it is and how atelectatic, and remove it with the 45-degree through biting Blakesley. And once we've removed that Ansner process, we will then have that's orbit. You can see you're right on the orbit. So that lamina papyracea is really thin and you're right on the orbit. And you can just see by us palpating that how that moved. So this is all orbital periosteum which is exposed here with that Ansner process right on it. So very atelectatic, just taking out a bit of the horizontal portion of the bone of the Ansner so that we don't have a lot of bone sitting between the two mucosal surfaces, because that prevents primary intention healing. So taking that bone out and exposing that maxillary ostium, you'll then just put the sucker in and you'll get a whole lot of thick and imposated material out of the maxillary sinus. And that's the maxillary sinus of this particular patient. But you can see that we're right on the lamina papyracea, and that this patient here, look here, there's all thin lamina papyracea. See, they're all thin, and it's very, very easy with your first incision there to have made an incision straight into the orbit. The key is recognition. So that's the key, is to recognize. The other concern is nasolacrimal duct injury. If you're using the backbiter and you've got a very underdeveloped Ansner process, so if you're thinking about using the backbiter with the technique that we've just described, the swing door technique, you've got to consider that when you're pulling that backbiter back, and if you pull it back hard, if you pull it back firmly, and you use force on it, you crunch hard and you've got solid bone, you've got a very good chance of injuring the nasolacrimal duct. So the key is to palpate with the tooth, to pull it back gently, and as you crunch, if you've got thick bone, if you've got significant resistance, it's not the Ansner process. The Ansner process is thin bone. It doesn't give significant resistance when you try and bite into it. If you bite into it and you're getting significant resistance, you're not biting only the Ansner process, you're likely to be biting the nasolacrimal duct as well. So palpation is important, and then that medial rotation of that backbiter, like I said, to turn with that last cut, to turn that backbiter at 45-degree angles brings you medial to the nasolacrimal duct. The other thing is that if you crush the nasolacrimal duct, it's much worse than it is if you open it. Now, I've opened a number of nasolacrimal ducts unintentionally with the technique. In other words, I've come back in and I've done a good bite, and boom, I see, there's a nasolacrimal duct. It's not a problem if you open the nasolacrimal duct. If you crush the nasolacrimal duct, you're much more likely to get a patient with symptoms afterwards than you are if you open it. So just be aware of that. If you open it, don't worry about it. Just leave it alone. The patient, in most cases, will have no side effects and no symptoms. We did 636 uncinectomies with the traditional technique, and we looked at a few outcome criteria. We wanted to see the number of orbital penetrations, the number of ostia we were unable to locate, and the number of nasolacrimal duct injuries that we could identify. In 636 consecutive ones, we had 6 orbital penetrations. As I said, everybody exposes orbital fat if you do enough. We had 42 ostia which we couldn't locate. We didn't have any nasolacrimal duct injuries. With the swing door technique, 636 consecutive cases, we had no orbital penetrations, and I think that is a fairly significant. And we identified the ostia in all of these patients. But we did have a nasolacrimal duct that we opened, and we exposed the mucosa of the nasolacrimal duct in 5. The typical result of the swing door technique is that you get a good exposure of the natural ostium with primary intention healing of that inferior aspect, no stenosis, because you really haven't done any trauma to this area of that natural ostium. You've only done a little bit of dissection on the inferior aspect, and you've gone and put those 2 flaps surface to surface. So the key of that technique is just take that little bit of bone out, trim down the excessive mucosa, and that gives you primary intention healing. I do think that the most important step in sinus surgery is the uncinectomy. I see in my practice 45-50% of my patients are referred to me by other ENT surgeons who failed. Patients had a FESS procedure and the FESS procedure has failed. And I would say 80% of those patients have been referred to me. They haven't done the first step correctly. What they've done is they've created a posterior fontanelle ostium and they've left the natural ostium intact, and you've got circular flow. So if you do the first step in FESS badly, you're going to end up with bad results. And it's the most common cause for revision surgery in all the patients who are referred to me. Thank you very much.